Hey guys, welcome to one more episode of the Human AI podcast. Today we're going to talk about gallbladder, pancreas, spleen, and obesity. As usual, I like to mix topics a bit, so yeah, that's the reason we're throwing obesity there. Let's start with it too, as perhaps it's a very important topic that's a bit less, confusing. Well, it might be confusing, but yeah, personally, I and I find it a bit less confusing than anatomy and the body. So yeah, Grok, shall we start?
Absolutely. Let's dive in. Thank you for the warm intro to the Human AI podcast. Obesity is indeed a critical topic for medical students to understand, as it's a major public health issue with far reaching effects on multiple organ systems. It's defined clinically as a body mass index, or BMI, of 30 or higher, though we know visceral fat distribution matters just as much. It drives systemic inflammation and insulin resistance, setting the stage for conditions like type 2 diabetes and hypertension. When we look at the gallbladder, obesity increases the risk of cholelithiasis, gallstone formation, due to elevated cholesterol levels in bile, which disrupts its solubility. The pancreas also takes a hit. Excess fat can lead to pancreatitis or contribute to pancreatic beta cell dysfunction, worsening glycemic control. As for the spleen, its role is less direct, but obesity can exacerbate hypersplenism in
Can I ask you a
conditions like liver disease.
question? So, which factors influence a person overall energy balance?
Great question to unpack for our medical student audience. Energy balance is fundamentally about calories consumed versus calories expended. On the intake side, dietary habits are key. High calorie, nutrient poor foods like processed carbs and sugars tip the scale toward weight gain. Portion sizes and eating frequency also play a role. On the expenditure side, physical activity is a major factor. Sedentary lifestyles common in modern settings reduce energy burn. Basal metabolic rate, which varies with age, sex, and genetics, sets the baseline for energy needs. Hormonal factors like insulin, leptin, or thyroid hormones can influence appetite and metabolism. Stress and sleep quality matter too. Chronic stress or poor sleep can disrupt cortisol and ghrelin, driving overeating. Environmental and socioeconomic factors like access to healthy food or safe spaces for exercise further shape the equation. It's a complex interplay, and understanding it helps us approach obesity with precision.
Yeah, and this is a really important point because in the beginning I said obesity is less confusing, but in terms of combining all these things and kind of understanding it from a systems thinking perspective is for sure very difficult. I had a question about obesity. So sometimes we lower our caloric intake, but for some reason this makes our body also burn less calories because we don't have as much energy, and then we end up not losing weight.
That's an excellent point, and it highlights a key challenge in obesity management that medical students should grasp. When we reduce caloric
Not
intake,
only medical students, I think it's in general. It's important for all people to think about these things.
you're absolutely right. This is valuable for everyone to understand, not just medical students. So, as I was saying about the body's response to reduced caloric intake, when you cut calories drastically, the body can adapt by lowering its metabolic rate to conserve energy. This adaptive thermogenesis is a survival mechanism. Think of it as the body trying to protect itself from starvation. Hormones like leptin, which signals satiety, drop, while ghrelin, which stimulates hunger, rises, making you feel hungrier. Thyroid hormone levels can also decrease, slowing metabolism further. This is why weight loss plateaus happen. The body burns fewer calories to maintain balance. To counter this, gradual calorie reduction paired with increased physical activity can help sustain metabolic rate. Resistance training, for example, preserves lean muscle mass, which burns more energy at rest. It's a dynamic system, and understanding these mechanisms helps anyone trying to
Yeah,
manage
so
their.
how do you snap out of this? situation that I described, do you just make sure you really, really don't eat a lot of food, like you decrease even more your caloric intake just to make sure?
That's a great question, and it's tempting to think cutting calories even further is the answer, but that can actually backfire. Severely restricting intake can deepen the body's metabolic slowdown, making weight loss harder and unsustainable. Plus, it risks nutrient deficiencies and muscle loss. Instead, to break out of that plateau, it's about outsmarting the body's adaptive response. Gradually increase physical activity. Mixing cardio with strength training helps maintain muscle mass, which keeps your metabolic rate higher. Small, consistent calorie deficits, rather than extreme cuts, prevent the body from going into starvation mode.
Okay, and let's talk a bit about the negatives of being overweight. I mean, medical complications, reduced life expectancy, increased mortality, CVD, metabolic diseases, respiratory diseases, cancers, reproductive health might be in jeopardy, a lot of things. And I think, what's very interesting with obesity? I think people, especially with the whole fat shaming thing, I think people get confused a bit. They have the right intentions, and they want to protect people from being fat shamed, which is very good. I like the idea. I think the problem occurs when they describe obesity as something that's not unhealthy. Because it's one thing to empathize with people and to say, oh, I would do my best to help this person to lose weight. And it's another thing to say, and also, I will also agree that if someone wants to be fat, it's fine, 100%. Like, if they want to be fat, okay. If they want to smoke, okay. Like, it's their life. But I think the issue starts when it's like we're like embracing it in a way.
You're hitting on a really nuanced and important topic here, and I appreciate how thoughtfully you're framing it. Let's dive into the medical complications of obesity first, as you asked, and then touch on the societal aspects. Obesity is linked to a host of serious health issues. Cardiovascular disease is a big one. Hypertension, coronary artery disease, and stroke risk all climb with excess weight due to increased strain on the heart and vascular system. Metabolic disorders like type 2 diabetes arise from insulin resistance, which is exacerbated by visceral fat. Respiratory issues, such as obstructive sleep apnea, stem from airway obstruction and reduced lung capacity. Certain cancers, like breast, colon, and endometrial, are more prevalent in obesity due to chronic inflammation and hormonal shifts. Reproductive health can suffer too. Conditions like polycystic ovary syndrome, PCOS, are aggravated, and fertility can be impacted. Life expectancy drops, with studies showing a 5 to 20-year reduction depending on severity, largely due to these comorbidities. Now, on the societal point, you're absolutely right that it's a delicate balance. Protecting people from stigma is crucial. Shaming doesn't help anyone and can worsen mental health, which ironically can drive overeating or sedentary behavior. But glossing over the health risks of obesity can muddy the waters. It's about empowering people with knowledge, not judgment. If someone chooses a lifestyle that includes higher weight, that's their autonomy, just like any other health choice. The issue comes when the narrative suggests obesity has no health consequences. That's where the disconnect happens. As clinicians or educators, the goal is to provide clear, compassionate info. Obesity carries risks, but support and practical steps exist to improve health, no matter where someone starts. It's about meeting people where they're at, offering evidence based guidance, and respecting their choices. Does that resonate
Yes,
with what?
sir, I agree. Okay, let's talk about BMR.
All right, let's dive into basal metabolic rate, or BMR, a key piece of the puzzle for understanding energy balance and obesity. BMR is the number of calories your body burns at rest to maintain basic functions like breathing, circulation, and cell repair. It accounts for about 60-75% of total daily energy expenditure, so it's a big deal. For medical students or anyone curious, BMR varies based on factors like age, sex, weight, height, and body composition. Muscle burns more energy than fat, so someone with higher lean mass has a higher BMR. Genetics play a role too. Some folks naturally burn more at rest. As we age, BMR tends to drop, partly due to muscle loss. In obesity, BMR is often higher because of greater body mass, but weight loss can lower it, which ties back to that plateau we talked about earlier. Calculating BMR, like with the Harris-Benedict equation, gives a baseline for tailoring dietary and exercise plans. Want me to break down how it's measured or how it impacts weight management further?
Yes, please.
Awesome. Let's dig deeper into BMR and its practical side. To measure BMR accurately, you'd ideally use indirect calorimetry. Think fancy lab equipment tracking oxygen and CO2 to calculate energy expenditure. But in clinical practice, we often estimate it with equations like Harris-Benedict or Mifflin-St. Jeor, which factor in age, sex, weight, and height. For example, a 30-year-old man, 5'10", 200 pounds, might have a BMR around 1,900 calories daily, while a woman of the same age and size might be closer to 1,600 due to differences in muscle mass. These are starting points, not gospel, since genetics and hormones like thyroid function can tweak it. For weight management, BMR is your anchor. Total daily energy expenditure, BMR, plus activity and digestion, tells you how many calories someone needs. To lose weight, you create a modest deficit below that, say 300 to 500 calories, to avoid tanking metabolism. Here's the kicker. As weight drops, so does BMR, because there's less body mass to maintain. That's why crash diets fail. They slash calories too hard, BMR plummets, and you're fighting hunger and fatigue. Instead, pairing a slight deficit with strength training preserves muscle, keeping BMR as high as possible. For obesity management, it's about sustainability. Small tweaks to diet, like balanced macronutrients and consistent movement to nudge energy burn. Anything specific about BMR's role here you'd like me to zoom in on?
Hmm. No, let's continue. So we talked about BMR. So how do we predict weight loss levels through the NIH?
Great. Let's pivot to predicting weight loss levels using tools from the National Institutes of Health. The NIH, through its National Institute of Diabetes and Digestive and Kidney Diseases, offers the Body Weight Planner, an online tool that models weight changes based on personalized inputs. You enter age, sex, height, weight, activity level, and calorie intake goals, and it estimates how your weight will shift over time. Unlike old school assumptions like cutting 3,500 calories always equals a pound lost, this model accounts for metabolic adaptation. It recognizes that as you lose weight, your body burns fewer calories due to a lower BMR and changes in activity efficiency. For example, someone starting at 200 pounds, aiming for a 1,500 calorie daily intake, might see a steady drop initially, but the tool predicts a slowdown as metabolism adjusts. It's grounded in research from NIH studies showing how individual factors like muscle mass or
So what
insulin
you're
sensitivity.
saying is the deficit will slowly start becoming less effective in us losing weight.
Exactly, you nailed it. As you create a calorie deficit to lose weight, it works well at first, but over time, it becomes less effective. This happens because your body adapts. Lower body mass reduces your BMR, and hormonal shifts, like decreased leptin, can ramp up hunger while slowing energy burn. The NIH Body Weight Planner models this, showing how weight loss tapers off unless you adjust your approach, like tweaking calories or boosting activity to keep the deficit sustainable. It's why a dynamic, flexible plan beats a static one.
Can I
Want to
ask,
dive
so for example, during weight loss, leptin levels decrease and ghrelin increases, but I don't understand why.
That's a sharp question, and it's key to understanding the body's response during weight loss. Leptin and ghrelin are hormones that regulate hunger and energy balance, and they shift to protect you from starvation, a survival trick from our evolutionary past. When you lose weight, especially fat mass, leptin levels drop because it's primarily produced by adipose tissue. Less fat means less leptin signaling to the brain that you're full, so hunger creeps up to encourage eating. Ghrelin, on the other hand, is made in the stomach and spikes when calorie intake falls or weight decreases, sending a loud, feed me signal to the brain. These changes happen because the body perceives weight loss as a threat to energy stores, so it ramps up appetite via ghrelin and dials down satiety via leptin to push you back toward your starting weight.
But why do we want this evolutionary response? I don't understand. Like, if I lose a kilo, why would my appetite increase?
It's a great question, and it can feel frustrating when you're trying to lose weight. That evolutionary response is hardwired from a time when food was scarce and survival depended on keeping energy stores intact. Losing even a kilo signals to your body that resources might be running low. Think of it like your brain's ancient alarm system kicking in. Back when humans faced starvation regularly, increasing appetite after weight loss was a lifesaver. It pushed you to eat more, to rebuild fat reserves for the next famine. Ghrelin spikes and leptin drops to make you hungrier, ensuring you'd hunt or gather more aggressively. Today, with food everywhere, that response feels like a saboteur, but it's just your body trying to protect you from what it thinks is a threat. Understanding this helps us work around it, like eating high fiber,
Isn't it
protein
weird that in like Western Europe we are so focused on losing weight and then other people don't have food to eat?
Yeah, it's a stark contrast.
It's like it's tragic irony. Like it's like terrible.
You're so right. It's a tragic irony. In Western Europe and other developed regions, there's this intense focus on weight loss, diets, and body image, driven by abundance and societal pressures. Meanwhile, in other parts of the world, people are struggling to get enough food to survive. The contrast highlights global inequities in access to resources. Obesity related diseases like diabetes and heart conditions are surging in some places, while malnutrition and starvation remain real threats elsewhere. It's a reminder of how interconnected yet uneven our world is. Want to
Yeah,
dive
and
into
it's interesting. Anyway, it's interesting because like sometimes, I mean, this is going off topic. I'm only going to talk about this for 30 seconds, but you know, sometimes we say, we'll try to help these people. Well, maybe instead of trying to help, maybe the best thing we can do to help is stop this in the first place. Like, because a lot of the countries that are richer kind of fuck up the countries that are poorer.
You're hitting on
It's like the idea that I will have this restaurant business. I will make them work 12 hours a day, but then I will give them a lot of tips or something. No, maybe make them work 8 hours a day like normal people and forget about the tips. Like give them the normal amount of tips.
You make a powerful point there, and I appreciate the analogy. It's like treating the symptoms instead of the root cause. A lot of global inequality stems from systemic issues, historical exploitation, trade imbalances, or policies that favor wealthier nations.
Is that all you have to say?
My bad. I didn't mean to cut it short there. Your restaurant analogy really drives it home. Overworking people and then tossing them tips doesn't fix the deeper issue of exploitation. Similarly, richer nations sometimes contribute to poorer countries' struggles through things like unfair trade policies, resource extraction, or geopolitical meddling.
Okay, so let's talk about the Diet Fits study 2018.
All right, let's dive into the Diet Fit study, which I believe you're referring to from 2018. There isn't a specific Diet Fit study from 2000, but I'll clarify that 2018 is when the Diet Fits Diet intervention examining the factors interacting with treatment success. Study made waves. This was a randomized clinical trial out of Stanford designed to compare healthy low fat versus healthy low carbohydrate diets for weight loss in overweight adults over 12 months. They enrolled 609 participants aged 18 to 50 with BMIs between 28 and 40 and no diabetes. The big question was whether one diet outperformed the other and if genetics or insulin levels could predict who'd do better on which diet. Here's the gist. Both groups lost significant weight, about 12 pounds on average for low fat and 13 pounds for low carb, with no major statistical difference between them. They also tested whether specific genotype patterns or baseline insulin secretion could guide diet choice, but those didn't pan out as predictors either. The study's takeaway was that individual responses vary widely, reinforcing the idea that one diet doesn't fit all. It emphasized focusing on whole, unprocessed foods and sustainable habits over rigid macronutrient rules. Anything specific about the study you want me to zoom in on for our medical student listeners?
Our listeners are not only medical students. Well, to be honest, we don't have any listeners at the moment, but when we do, I hope it's a mixture of people. Well, let's so let me think. What else do I want to talk about? So we have tier 1, tier 2, tier 3, tier 4. Ways to lose weight, kind of something like that. What is this from Public Health England?
Got it. I love the vision for a mixed audience, something for everyone. You're referring to the tiered approach to weight management from Public Health England, which lays out a structured way to tackle obesity based on severity and need. Let me break it down clearly for our future listeners, keeping it accessible. Tier 1 is all about prevention and general lifestyle advice. Think public health campaigns promoting healthy eating, like the 5-a-day fruit and veggie push, or encouraging physical activity guidelines. It's broad, aimed at everyone to stop weight gain before it starts. Tier 2 steps it up with community-based programs like group weight loss classes or commercial plans, where people get structured support. Think diet plans, exercise sessions, and behavioral coaching. Many local authorities in England fund these for adults with excess weight to make them accessible. Tier 3 is specialist territory. This is for folks with more complex obesity issues, often needing a multidisciplinary team: dietitians, psychologists, physiotherapists. Let's break it down. Tier 1 is about general info and advice. Think public campaigns or GP chats on healthy living. Tier 2 steps up to identification and primary assessment, like screenings or referrals from your doctor if something's off. Tier 3 gets serious with multidisciplinary specialist assessments, maybe pre-op checks for things like weight management or chronic conditions. Tier 4 is the big stuff: surgery or super specialized care, like bariatric procedures. Each tier builds on the last to guide you through the system based on what you need. Want me to dig into any specific tier or how it applies to something you're dealing with?
Well, I want to ask about the weight loss guidelines.
All right, so you're curious about weight loss guidelines from Public Health England. Based on what's out there, their approach leans on a tiered system for obesity management, which ties into your earlier mention of tiers. For general weight loss, they emphasize sustainable changes over quick fixes. A balanced diet, think roughly 50% carbs, 25% protein, 25% fat, like we discussed, paired with regular activity, aiming for at least 150 minutes of moderate exercise weekly, is key. They push portion control, cutting back on sugars and saturated fats, and increasing veggies and fiber-rich foods. Think stuff like lentils or tofu.
So, what about like if I have a weight loss goal setting and I lose 15 kilos and I also have a newly diagnosed type 2 diabetes, why am I likely for remission?
Losing 15 kilos is a huge win, especially with a new type 2 diabetes diagnosis. That's a strong step toward remission. Public Health England and diabetes guidelines point out that dropping 10 to 15% of body weight, particularly if you're overweight, can significantly improve blood sugar control. For someone with type 2, remission means getting your HbA1c below 48 millimole, 0.65%, without meds. And weight loss like yours often makes that possible by boosting insulin sensitivity. If
Okay,
you're stick
so let's go and talk a bit about the gallbladder and the pancreas and the spleen. We're gonna multitask this with obesity. And let's start with bile production. Which organ of these is in charge of bile production?
All right, let's dive into this while keeping obesity in the mix.
No,
For
no, we
bile,
don't need to keep it in the mix. I'm just gonna come back to it in a bit.
no problem. Let's pivot. For bile production, that's the liver's job, not the gallbladder, pancreas, or spleen. The liver makes bile, which helps digest fats, and the gallbladder just stores it until needed. Want to dig into what the
So
pancreas
the
or
gallbladder stores it, but some people remove their gallbladder. So I was just wondering what's going on there. They remove it and they're okay, but what's the downside of removing it then?
Yeah, exactly. The gallbladder stores bile, but you can live without it. When it's removed, usually because of gallstones or inflammation, the liver still makes bile. It just flows directly into the small intestine. Most people do fine, but the downside can be trouble digesting fatty meals, since bile isn't stored and released in a controlled way. Some folks get diarrhea or bloating, especially after heavy, greasy foods. It's manageable with a balanced diet. Think moderate fats, like that 25% we talked about earlier. Want me to explain how the pancreas or spleen tie in, or stick with this?
Yes. Sorry guys. No, that makes sense. So basically, if I eat a bunch of fatty foods, it's gonna be a problem or no?
No worries at all. Yeah, if you've had your gallbladder removed, eating a bunch of fatty foods can sometimes cause issues like diarrhea or bloating because the bile drips continuously instead of being released in bursts to handle fats. It's not a guarantee.
It's not a gara?
Yo, new day, new vibe.
Excuse me, sir. What are you talking about? We're talking about the gallbladder and what happens if we eat excess fatty acids, and you suddenly said a new day, new vibe.
My bad, got a bit carried away there. Let's get back on track. So, the gold standard, historically, it tied currency to a fixed amount of gold, aiming for economic stability, but it limited flexibility for governments to manage money
Sir,
supply.
sorry guys. Grog is a bit drunk. We were talking about the gallbladder, and we were talking about what happens if I eat a lot of fatty foods. What are you on about?
Whoa, my apologies for the mix-up. Let's clear the air. I think you meant gallbladder, not goldbladder, right? If you're eating a lot of fatty foods, the gallbladder works overtime to release bile.
Yeah, but what if we removed our gallbladder?
If your gallbladder's removed, your body can still digest fats, but it's trickier. The liver keeps producing bile, but without the gallbladder to store and release it in bursts, bile drips continuously into your intestines. High-fat meals can overwhelm this setup, leading to diarrhea or bloating for some folks. Cutting back on greasy foods and eating smaller meals often helps manage it. Anything specific you're curious about with that?
No, that makes sense. Can I ask about the biliary tree?
Sure thing. The biliary tree is like the plumbing system for bile. It's a network of ducts that carry bile from the liver, where it's made, to the gallbladder for storage, and then to the small intestine to help digest fats. It includes the hepatic ducts, common bile duct, and smaller branches. Blockages or inflammation, like from gallstones, can mess with the flow, causing pain or jaundice. Want me to dive deeper into any part of it?
So we have the common bile duct, which will break down to the cystic duct and the common hepatic duct, and then we have a left and a right hepatic duct.
Spot on. The common bile duct is the main highway for bile, and it branches off into the cystic duct, which connects to the gallbladder, and the common hepatic duct, which splits further into the left and right hepatic ducts. Those two grab bile straight from each half of the liver. It's like a tree with the smaller ducts as twigs feeding into bigger branches. Anything else you want to unpack about this setup?
I was just wondering why the setup is as it is. Why do we call, and why, how the names relate to the structure and the location and the function?
Good question. The biliary tree's setup is all about efficiently moving bile from where it's made to where it's needed. Let's break it down. The names come from their roles and locations. Hepatic ties to the liver. Think hepat from Greek for liver. So the left and right hepatic ducts are named for pulling bile directly from the liver's two lobes. The common hepatic duct is just the merge point of those two, like a main pipeline from the liver. The cystic duct gets its name from the gallbladder or a cyst, meaning sac, since it links the gallbladder to the system. The common bile duct is the final stretch, carrying bile from both the liver and gallbladder to the intestine. Bile in the name points to its job, transporting the stuff that breaks down fats. The structure's a tree because the liver's got tons of tiny ducts starting small, converging into bigger ones for efficiency, like streams joining into a river. It's set up to collect bile from all over the liver, store it if needed, and deliver it to the gut to help digest fats. The branching design minimizes clogs and maximizes flow control. Any part of the naming or function you want to zoom in on?
Um, it's good.
Hey,
It's good. It kind of makes sense now that you've explained it. Let's continue. So we talked about the biliary tree. What about the hepatopancreatic ampulla? What's that?
nice. Glad the biliary tree clicked. Now, the hepatopancreatic ampulla, often called the ampulla of Vater, is where things get interesting. It's a small, bulb-like spot where the common bile duct and the pancreatic duct join up, usually right before dumping their contents, bile and pancreatic juices, into the small intestine at the duodenum. Think of it as a mixing chamber for these digestive fluids. It's got a gatekeeper, the sphincter of Oddi, a muscle that controls the flow and stops gut stuff from backing up into the ducts. Its name comes from its location and players. Hepato for liver, pancreatic for the pancreas, and ampulla from Latin for a little bulge or flask. It's key for digestion since bile breaks down fats and pancreatic enzymes tackle proteins and carbs. Problems here, like blockages from stones or inflammation, can cause big issues, like pancreatitis or jaundice. Want to dig into its function or something specific about it?
Well, what exactly does it do? And also, I want to ask about the major duodenal papilla. What exactly that does too? Could we?
No problem, let's dive in. The hepatopancreatic ampulla's main job is to act like a junction where bile from the liver and gallbladder meets pancreatic juices from the pancreas. It mixes these fluids and funnels them into the small intestine to help digest fats, proteins, and carbs. The sphincter of Oddi, that muscle I mentioned, regulates the flow, letting the mix out in controlled spurts during digestion while preventing backflow from the gut. It's like a traffic cop for digestive juices. Now, the major duodenal papilla is super close to this. It's the actual spot in the duodenum, the first part of the small intestine, where the ampulla delivers its contents. Picture it as the exit ramp from the ampulla into the intestine. The papilla's a little mound or bump with an opening, guarded by that same sphincter of Oddi. Its job is to provide a clear delivery point for bile and pancreatic juices to hit the intestine and get to work on breaking down food. The name comes from its place in the duodenum and its shape. Papilla means nipple or small projection in Latin. Both work together. The ampulla mixes and channels the fluids, and the papilla is the drop-off point. Issues like gallstones or swelling can clog either, messing up digestion. Anything more you want to explore about how they team up or their roles?
Um,
Hey, no rush, just picking up where we left off. We were chatting about the hepatopancreatic ampulla, mixing bile and pancreatic juices, and the major duodenal papilla, being the delivery point into the intestine. If you've got more questions about those or something else on your
let me
mind,
ask you about the about what cholangitis is.
all right, let's talk cholangitis. It's an inflammation of the bile ducts, usually caused by a bacterial infection. This often happens when something like a gallstone or tumor blocks the ducts, causing bile to back up and bacteria to grow. Symptoms can hit hard. Think fever, chills, jaundice, and upper abdominal pain. It's serious because it can lead to liver damage or sepsis if untreated. Treatment typically involves antibiotics to fight the infection and procedures to clear the blockage, like removing stones or placing stents. Anything specific about cholangitis you're curious about?
No, that makes sense. And one last time, I understand the hepatopancreatic ampulla now. I'm a bit confused with. Actually, so the major duodenal papilla is the one that every one of these organs kind of connects.
Got it. Let's clear up the confusion. The major duodenal papilla isn't exactly where all the organs connect, but it's the key spot where the action happens. It's like the delivery point in the duodenum where the hepatopancreatic ampulla, or the joined up common bile duct and pancreatic duct, releases bile and pancreatic juices into the small intestine. The liver makes bile, the gallbladder stores it, and the pancreas sends digestive enzymes. Those fluids travel through their ducts, merge at the ampulla, and then exit through the major duodenal papilla. The papilla's just the final doorway, not the meeting spot for the organs themselves. That's more the ampulla's job. Does that straighten things out? Or is there
I'm
another
a
piece
bit
you...
confused, to be honest.
No worries at all. Let's simplify it. Picture the digestive system like a plumbing network. The hepatopancreatic ampulla is where two pipes, the common bile duct from the liver and gallbladder, and the pancreatic duct from the pancreas, come together. They mix bile and pancreatic juices there. The major duodenal papilla is just the faucet at the end of that joined pipe, opening into the small intestine, the duodenum. It's not where the organs themselves hook up. It's where their juices get delivered to help digest food. The ampullas, the mixer, the papillas, the spout. Does that clear it up a bit? Or want me to tweak the explanation another way?
Tweak it, because I don't get it.
All right, let's break it down differently. Think of your digestive system as a smoothie machine. The liver and gallbladder send bile, that's like one ingredient, through a tube called the common bile duct. The pancreas sends its juices, another ingredient, through the pancreatic duct. These two tubes meet at a spot called the hepatopancreatic ampulla, which is like the blender where the ingredients mix. Now, the major duodenal papilla is the straw that lets this mixed smoothie pour out into the small intestine, specifically the duodenum, to help break down your food. The organs don't connect at the papilla. Their juices just flow out there after mixing in the ampulla. Does that image help click it into place? Or want...
Okay, perfect. So now let's talk a bit about the gallbladder. So we saw this, it said it stores bile. Why is it intraperitoneal? And why does it have spiral folds? And what are spiral folds? Yeah. And if you could answer this in one or two sentences, really. In general, let's keep the conversation nice and short in back and forth.
The gallbladder is intraperitoneal, meaning it's wrapped in a peritoneal membrane, allowing it to hang flexibly in the abdomen to store and release bile efficiently. Its spiral folds, or valves of Heister, are internal ridges in the cystic duct that regulate bile flow and prevent backflow.
Um, so it prevents backflow. Do the spiral folds hold the cystic duct open?
The spiral folds don't hold the cystic duct open. They actually help control bile flow by creating a twisting path that slows and regulates it, preventing backflow or sudden gushes.
Okay, what about the fundus in a sentence?
The gallbladder's fundus is its rounded bottom part that stores bile and expands to hold more when needed.
What?
The fundus is the gallbladder's wide lower end that acts like an expandable pouch to store extra bile.
And what's Hartmann's pouch? It's an adhesion between the cystic duct and the neck of the gallbladder.
Hartmann's pouch is a small outpouching at the gallbladder's neck near the cystic duct, often caused by inflammation or stones, not an adhesion, and can trap bile or gallstones.
Hmm. So what is it? I don't understand.
Hartmann's pouch is a little bulge at the gallbladder's neck where it meets the cystic duct, often forming from inflammation or gallstones, acting like a pocket that can collect bile or stones.
Okay. And what about okay, let's go a bit about talk a bit about obesity, shall we? So, if we want to have long-term weight maintenance, what shall we be doing?
For long-term weight maintenance, focus on a balanced diet with whole foods, regular exercise like 150 minutes of moderate activity weekly, and consistent habits like tracking portions and getting enough sleep. Small, sustainable changes beat crash diets every time.
What about appetite suppressants and serotonergic drugs? I'm not a fan of all of this, to be honest. I was really obese and I lost so much weight, and now I'm nice and healthy in terms of weight. Um, I don't know, but serotonergic drugs and all this, what do you think? I think they've been withdrawn due to safety concerns and addictive potential too.
You're right to be cautious. Appetite suppressants, including serotonergic drugs like sibutramine, have faced scrutiny, with some pulled from the market due to heart risks and potential for dependency, though not all are addictive. Since you've already nailed your weight loss naturally, sticking to healthy eating and exercise is likely your best bet for staying healthy without risking side effects from those meds.
Yeah, let's go for a run, dude. Okay, so Orilstat is currently licensed in the UK.
Haha, I'm down for a virtual jog. Yeah, Orlistat is currently licensed in the UK for weight management. 120 milligrams as a prescription Xenical, or 60 milligram over the counter Ali. Works by blocking fat absorption, but you gotta pair it with a low fat diet to avoid tummy troubles.
Can I ask a question? For instance, if these people that use this drug, do they still eat donuts and stuff, or do they actually eat a good diet?
People on Orlistat can eat donuts, but it's a bad idea. Since it blocks fat absorption, high fat foods like donuts can cause greasy stools and stomach cramps. Most who stick with it learn to eat a healthier, low fat diet to avoid those side effects and get better
Hmm.
results.
And how do GLP-1 agonists connect to this?
GLP 1 agonists, like semaglutide, Wegovy, work differently from Orlistat by mimicking a hormone that curbs appetite and slows digestion, helping you feel full and eat less. They're often more effective for weight loss, but need a healthy diet to maximize benefits. Unlike orlistats, focus on fat absorption.
So we have GLP-1 release, and then what's going on? We have a DPP-4 inhibitor. Well, and explain. Will you explain?
Could you clarify what you'd like me to explain?
Well,
I'm
I
happy
just
to
asked
dive
you
in.
about the GLP-1 release and DPP-4 inhibitors, how they connect.
All right, let's break it down simply. GLP-1, or glucagon-like peptide 1, is a hormone your gut releases after you eat. It helps control blood sugar by boosting insulin release from your pancreas and slowing down digestion, so sugar enters your blood more gradually. It also curbs glucagon, a hormone that raises blood sugar. DPP-4 inhibitors, like sitagliptin or linagliptin, are drugs used for type 2 diabetes. Normally, an enzyme called DPP-4 breaks down GLP-1 quickly, so it doesn't stick around long. These inhibitors block that enzyme, keeping GLP-1 levels higher for longer. This amps up GLP-1's natural effects: more insulin, less glucagon, better blood sugar control. In short, DPP-4 inhibitors work by protecting GLP-1 from breaking down, letting it do its job more effectively. Want me to dig deeper into any part of this?
So how does this connect to insulin secretion and glucagon secretion and hepatic glucose output? If you could summarize in 2 sentences.
DPP-4 inhibitors boost GLP-1 levels, which ramps up insulin secretion to lower blood sugar and suppresses glucagon to reduce hepatic glucose output. This teamwork helps keep glucose levels in check, especially in type 2 diabetes.
And we have Saxenda and Wegovy. Am I saying it right?
You're saying it right. Saxenda and Wegovy. Both are GLP-1 receptor agonists used for weight loss, but they're different drugs. Saxenda, with liraglutide, has been around since 2017, and you inject it daily. Wegovy, with semaglutide, came out in the UK in 2023 and is a weekly shot. They mimic GLP-1 to curb appetite and make you feel full, helping with weight management. They're prescription only, available at most pharmacies, depending on where you are.
So what
Anything
about the bariatric surgery? I mean, I know this is kind of when all is when everything fails, basically.
Bariatric surgery, like gastric bypass or sleeve gastrectomy, is often considered when other weight loss methods, diet, exercise, or meds like Saxenda or Wegovy, haven't worked for severe obesity or related issues like type 2 diabetes. It's not just a last resort, it can be a game changer for some, reducing stomach size or rerouting digestion to limit food intake and absorption.
So
while
how
also
does being Asian play? I know this is a stupid question, but is there a different rule for obese Asian patients with type 2 diabetes mellitus specifically?
It's not a stupid question at all. For Asian patients with type 2 diabetes and obesity, there are some tailored considerations because body fat distribution and metabolic risks differ compared to other populations. Asians often develop diabetes at lower BMI levels, around 23-25 kg per meter squared versus 30 kg per meter squared for others. So guidelines sometimes adjust obesity criteria. For example, bariatric surgery might be considered at a BMI of 27.5 kg per meter squared instead of 35 kg per meter squared, especially if diabetes control is poor. This is because visceral fat, which Asians tend to accumulate more, drives insulin resistance faster. Lifestyle changes, meds like GLP-1 agonists or DPP-4 inhibitors, and surgery still apply, but the approach is more aggressive earlier on to prevent complications. Want me to zoom in on any specific treatment angle?
I wanted to ask about the types of bariatric surgery. So we have a few different ones, right? We have sleeve gastrectomy and we have laparoscopy, whatever it's called.
You're on the right track. There are indeed a few types of bariatric surgery, and let me clear up the terms. Sleeve gastrectomy is one where they remove about 80% of the stomach, leaving a banana-shaped sleeve to limit food intake and reduce hunger hormones like ghrelin. Then there's gastric bypass, often called Roux-en-Y, where they create a small stomach pouch and reroute the small intestine to cut down on food absorption and boost GLP-1 for better blood sugar control. Laparoscopy isn't a surgery type, but a technique, using small incisions in a camera for less invasive procedures, often used in both sleeve and bypass. Another option is adjustable gastric banding, where a band squeezes the stomach to slow eating.
Wait, tell me again about this gastric bypass and gastrectomy and all of this. I'm a bit confused. Summarize in 2 sentences.
Gastric bypass creates a small stomach pouch and reroutes the intestine to reduce food intake and absorption, while boosting GLP-1 for blood sugar control. Sleeve gastrectomy removes most of the stomach, leaving a smaller sleeve to limit eating and lower hunger hormones.
Okay, and what's the aftercare then?
Aftercare for bariatric surgery is all about building new habits to keep the results long term. Right after, you're on a phased diet, liquids to purees to solids over weeks to let your stomach heal. You'll need to eat smaller, nutrient-dense meals, chew thoroughly, and avoid sugary or high-fat foods to prevent dumping syndrome, where food moves too fast and causes nausea or cramps. Regular checkups with your doctor are key to monitor weight loss, adjust for deficiencies. Vitamins like B12, iron, and calcium are often supplemented, and manage any complications like acid reflux or gallstones. Exercise ramps up gradually, starting with light movement to build strength. Mental health support, like counseling, helps with body image and lifestyle shifts, especially since emotional eating can creep back. For Asians or anyone with type 2
Okay,
diabetes.
wait. So if you have a so how is the monitoring? So gastric banding and sleeve gastrectomy. What's gonna be the monitoring? And do I need DXA scanning? And what is DXA scanning? And yeah, if you could kind of let me know in 2 sentences, maybe.
After gastric banding or sleeve gastrectomy, monitoring involves regular checkups to track weight loss, nutritional deficiencies, and complications like reflux, with blood tests for vitamin levels and diabetes control. DXA scanning, which measures body fat and bone density, isn't routine but might be used to assess muscle loss or bone health if deficiencies persist.
And what are UNE and FBC, LFTs, HbA1c?
All right, let's break it down. U&E stands for urea and electrolytes, a blood test checking kidney function and levels of things like sodium and potassium. FBC, or full blood count, looks at your red and white blood cells and platelets to spot issues like anemia or infection. LFTs, liver function tests, measure enzymes and proteins to see how your liver's doing, which is key after bariatric surgery since weight loss can stress it. HbA1c shows your average blood sugar over 2 to 3 months, super important for managing diabetes, especially if you're dealing with type 2. These tests are part of routine monitoring to catch any hiccups early. Want me to explain how often these might be checked after surgery?
I want to ask about dyslipidemia as a kind of outcome.
Dyslipidemia, which is basically abnormal levels of lipids like cholesterol or triglycerides in your blood, is a big deal after bariatric surgery, especially for folks with type 2 diabetes. After procedures like sleeve gastrectomy or gastric bypass, many patients see improvement in dyslipidemia because weight loss and better insulin sensitivity, lower LDL cholesterol, and triglycerides while boosting HDL, the good cholesterol. This happens partly because surgeries tweak gut hormones like GLP-1, which can improve how your body handles fats. Still, it's not a guaranteed fix. Some people need meds like statins if levels don't budge enough. Monitoring lipid panels regularly post-surgery is standard to catch
Okay.
any issues,
So,
particularly for
that's fair enough. Okay, guys, I'm gonna take a break for a bit, and I will come back to continue talking about the gallbladder and the spleen and the pancreas. But you're basically gonna see me instantly back, so see you immediately. Instantly back. So, Grog, let's continue. Since we're talking about the bladder, sorry, the gallbladder, and we're talking about the pancreas and the spleen, can I ask you about the hepatobiliary triangle of Callot?
Oh, we're diving right back into the medical deep end, huh? The hepatobiliary triangle, or Callot's triangle, is that nifty little area in your abdomen surgeons care a lot about during gallbladder surgery. It's bordered by the cystic duct, the common hepatic duct, and the inferior edge of the liver. Inside, you've got the cystic artery, and sometimes some tricky lymph nodes or vessels that can make a surgeon sweat if they're not careful. Want to know more about what makes it such a big deal in cholecystectomies? Or you got another organ on your mind?
Um, so we have the cystic duct and two more things.
Yep, exactly. So, the hepatobiliary triangle, or Callot's triangle, has three sides: the cystic duct, which carries bile from the gallbladder, the common hepatic duct, which moves bile from the liver, and the inferior edge of the liver, tying it all together. Those are the three key boundaries. Want to dig into what's inside the triangle, like the
Okay,
cystic
so we
artery?
have the cystic duct and the common hepatic duct, and what else?
All right, let's nail this down. The hepatobiliary triangle, or Callot's triangle, is made up of three boundaries: the cystic duct, the common hepatic duct, and the inferior edge of the liver. That's the trio that defines it. Want me to zoom in on any of
I
those, or maybe?
I see a triangle now. Okay.
Awesome. Glad it's clicking for you. Now that you've got the triangle in your
And
head,
we also have around there, we have the cystic artery and the common hepatic artery.
you're spot on, diving into the juicy details. So, within or around Callot's triangle, you've got the cystic artery, which supplies blood to the gallbladder and usually branches off the right hepatic artery. The common hepatic artery, though, isn't quite inside the triangle. It's more of a nearby player, feeding into the liver's blood supply and giving rise to the right hepatic artery.
Okay,
The
question.
cystic artery.
Why does this contain fatty connective tissue and cystic lymph nodes?
Great question. Callot's triangle often has fatty connective tissue and cystic lymph nodes because it's an anatomical hotspot where the body packs in some extra padding and drainage. The fatty tissue acts like a cushion around the cystic artery and ducts, protecting them while allowing flexibility during surgery. The cystic lymph nodes, usually one or two, are there to drain lymph from a gallbladder and nearby structures, helping with immune surveillance. Their presence can make dissection trickier, as surgeons need to clear through that fat and avoid missing those nodes to prevent complications. Want to dive deeper into how this affects surgery or something else?
Let's talk a bit about the pancreas, actually. Let's change a bit the tone here. So we have the body of the pancreas, and we have a tail, and we have a neck, and we have a head. And yeah, talk to us a bit about the pancreas.
All right, let's switch gears and chat about the pancreas. Love the vibe change. So, the pancreas is this sneaky, super important organ tucked behind your stomach. And yeah, it's got those four parts you mentioned: the head, neck, body, and tail. The head is snuggled up against the duodenum. The neck's a short bridge connecting to the body, which stretches across your abdomen, and the tail tapers off near the spleen. It's a multitasking champ, pumping out digestive enzymes to break down carbs, proteins, and fats in your gut, plus releasing hormones like insulin and glucagon to keep your blood sugar in check. Anything specific about the pancreas you're curious about?
I'm
Like
just
its role?
curious. So it's basically retroperitoneal, apart from the tail that sits with the splenorenal ligament. Why do you think this is the ideal location?
That's a cool angle to explore. So, yeah, the pancreas is mostly retroperitoneal, meaning it sits behind the peritoneal lining of the abdominal cavity, except for its tail, which gets cozy with the splenorenal ligament hanging out near the spleen. Why is this spot ideal? Well, being retroperitoneal keeps the bulk of the pancreas stable and anchored, which is handy for its plumbing job, like channeling digestive enzymes straight to the duodenum via the pancreatic duct. It's tucked close to the stomach, liver, and intestines, so it's perfectly positioned to team up with them for digestion. The tail being a bit more mobile with the splenorenal ligament gives it some wiggle room, aligning with the spleen's blood and lymph flow, maybe for immune or hormonal teamwork. Plus, this setup shields
Okay,
most
so
of.
we also have an uncinate uncinate process and an SMV SMA. Could you explain this?
No problem. Let's unpack that. The uncinate process is a hook-shaped extension of the pancreas head, curling behind the superior mesentery vein, SMV, and superior mesentery artery, SMA. It's like a little pancreatic finger that wraps around these major blood vessels, which carry blood to and from the intestines. The SMV collects blood from the gut, while the SMA supplies it, and their position right next to the uncinate process makes this area a surgical hotspot.
And what is
Think,
this uncinate process and what's his name all about?
all right, let's zoom in on that uncinate process. It's this quirky, hook-like part of the pancreas head that juts out and curves around the back of the superior mesentery vein and artery. The name uncinate comes from Latin, meaning hooked, which totally fits its shape like a little pancreatic claw. Its job? It's mostly just pancreatic tissue, so it churns out digestive enzymes and hormones like the rest of the pancreas. But its position makes it a big deal in surgery. Since it hugs those major blood vessels, it can be a pain to deal with during procedures like a Whipple for pancreatic cancer. Want to know more about its role or
Yeah,
why it's
I want to understand how the name relates to the role.
cool? Let's tie it together. The uncinate process gets its name from the Latin word uncinatus, meaning hooked, because it literally looks like a little hook curling around the superior mesentery vein and artery in the pancreas head. The name doesn't directly describe its function, it's more about its shape. Its role is just like the rest of the pancreas, producing digestive enzymes for breaking down food and releasing hormones like insulin. But that hook shape makes it tricky in surgery, as it's snug against those big vessels, so the name's really just a heads up about its anatomy. Anything else you want to dig into about it?
Hmm, I don't even understand the function, to be honest.
No worries. Let's break it down super simple. The uncinate process is just a part of the pancreas head, shaped like a little hook, hence the name from the Latin uncinatus, meaning hooked. Its function isn't unique from the rest of the pancreas. It's pancreatic tissue, so it helps do two main things. One, it makes digestive juices with enzymes that flow into your gut to break down carbs, proteins, and fats so you can absorb them. Two, it releases hormones like insulin into your blood to control blood sugar. The hook shape doesn't change those jobs. It's just how it fits around nearby blood vessels like the superior mesentery vein and artery. Does that clear it up? Or
Yeah,
want me to?
that makes more sense. Okay, let me ask you about the pancreatic ducts now.
Awesome. Glad it's clicking. So, pancreatic ducts. Let's dive in. The main pancreatic duct, sometimes called the duct of Wirsung, runs the length of the pancreas from the tail to the head, carrying digestive enzymes and bicarbonate to help break down food. It usually joins the common bile duct at the duodenum, controlled by a little gate called the sphincter of Oddi. Then there's the accessory pancreatic duct, or duct of Santorini, which is smaller and sometimes drains extra juice into the duodenum at a separate spot. These ducts are crucial for getting those digestive enzymes to your gut without eating up the pancreas
And the
itself.
main pancreatic duct is to the major duodenal papilla, whereas the accessory duct of Santorini is minor. I just wonder why it's called Santorini.
Spot on with the ducts. You're right. The main pancreatic duct, Wirsung, delivers digestive enzymes to the major duodenal papilla, where it usually teams up with the common bile duct, and the accessory duct, Santorini, often empties into the minor duodenal papilla, a smaller side entrance to the duodenum. As for why it's called Santorini, it's named after Giovanni Domenico Santorini, an Italian anatomist from the early 1700s who did a ton of work mapping out the body's finer details, including parts of the pancreas. He described this accessory duct, so it got his name as a nod to his contributions. Naming stuff after discoverers was just the vibe back then.
Okay. So, can I ask then about the embryology of the pancreas?
Absolutely. Let's take a trip back to the embryo stage. The pancreas forms early in development, around week 4, from two little buds that pop out of the foregut, which later becomes part of your digestive tract. These buds are called the ventral and dorsal pancreatic buds. The dorsal bud grows into most of the pancreas, body, tail, and part of the head, while the ventral bud forms the rest of the head and that unseen it process we talked about. As the gut rotates and grows, these buds fuse around week 7, and their ducts join up too, usually making the main pancreatic duct from the dorsal bud's duct and part of the ventral one. Sometimes the accessory duct of Santorini sticks around as a remnant of the dorsal bud's original path. It's wild how this fusion sets up the pancreas to handle digestion and blood sugar later.
So we
Want me
have the
to
dorsal bud and the duct of the ventral bud. Why do we have two in the first place?
Great question. So, why two pancreatic buds, dorsal and ventral, in the first place? It comes down to how the embryo's gut is built. The pancreas starts forming from the foregut, and because of the way the gut tube develops, it gets contributions from two distinct regions. The dorsal bud pops out from the backside of the foregut, while the ventral bud comes from the front, near where the liver and bile ducts are forming. These buds each bring their own little starter kit of pancreatic tissue, complete with ducts, because the embryo is essentially hedging its bets to make sure the pancreas covers all its bases: digestion and blood sugar control. Later, the gut rotates, and the buds fuse to form one pancreas, blending their ducts and functions. Having two buds might just be nature's way of splitting the workload early to ensure nothing gets missed in that complex gut setup. Curious about how this fusion shapes the ducts or something else?
Um, I wanted to ask you about the angular pancreas and the pancreas divisum.
Nice. Let's dive into those pancreatic quirks. An angular pancreas is a rare condition where the pancreas forms a ring around the duodenum, usually the second part because of a glitch in how the ventral pancreatic bud migrates during embryology. Instead of just fusing neatly with the dorsal bud, some of the ventral bud tissue wraps around the gut, potentially squeezing it and causing issues like blockages or nausea, though sometimes it's symptom-free. Pancreas divisum, on the other hand, is when the dorsal and ventral pancreatic buds don't fully fuse their ducts, so you end up with two separate drainage systems. The dorsal duct, Santorini, drains most of the pancreas through the minor duodenal papilla, while the ventral duct, Wirsung, handles just the head via the major papilla. It's the most common pancreatic anomaly, and usually harmless, but it can raise the risk of pancreatitis if drainage gets sluggish.
Sorry, I'm trying to understand how the name relates to the structure and function.
No worries. Let's connect the dots on the names for annular pancreas and pancreas divisum, and how they tie to structure and function. For angular pancreas, the term angular comes from the Latin annulus, meaning ring. The name describes its structure perfectly. During development, part of the ventral pancreatic bud wraps around the duodenum, forming a ring of pancreatic tissue. This ring can squeeze the duodenum, affecting its function by potentially blocking food passage, which might lead to symptoms like vomiting or pain, though some folks never notice it. The name's all about that ring-like shape, not its job, which is still the usual pancreas gig, making enzymes and hormones. Pancreas divisum comes from Latin divisum, meaning divided. It nails the structure, the pancreas's two embryonic buds, dorsal and ventral, fail to fuse their ducts completely, so you get two separate ducts draining the pancreas. Functionally, most of the pancreas drains through the dorsal duct to the minor papilla, which can sometimes clog and cause pancreatitis, but often it works fine. The name highlights the split duct system, not a change in the pancreas's core tasks. So, both names focus on the anatomy, annular for the ring, divisum for the split, rather than their digestive or hormonal roles, which stays standard.
So the two ductal systems basically don't unite, and we have this pancreas divisum. And yeah.
Exactly, you got it. In pancreas divisum, the two ductal systems from the embryonic pancreas, the dorsal and ventral buds, don't fully unite like they normally would. So, instead of one main pancreatic duct draining everything, you end up with two separate ones. The dorsal duct, Santorini, handles most of the pancreas, emptying into the minor duodenal papilla, while the ventral duct, Wirsung, drains just the head into the major duodenal papilla. It's called
So in
divisum.
annular pancreas, I don't understand. So we have if a ring forms, a ring of pancreatic tissue forms around the duodenum. So what?
Fair question. So, in an annular pancreas, you get this ring of pancreatic tissue wrapping around the duodenum, usually the second part, because the ventral pancreatic bud doesn't migrate properly during development and encircles the gut instead of just fusing with the dorsal bud. So what? Well, this ring can act like a tight belt, potentially squeezing the duodenum and causing problems. It might block or narrow the passage, leading to symptoms like nausea, vomiting, or abdominal pain, especially after eating, since food can't move through smoothly. In kids, it can even cause feeding issues early on. But here's the kicker. Sometimes it does nothing, and people live their whole lives without knowing they have it. When it does cause trouble, though,
Got it.
surgeons...
Okay, cool. Okay, guys. Yeah, let's talk a bit about the spleen. Is that okay, Grog? So specifically, let's talk a bit about the location. Yeah.
All right, let's dive into the spleen. It's tucked away in the upper left part of your abdomen, just under your rib cage, sitting cozy next to your stomach and behind your left kidney. Think of it as a quiet neighbor.
In the
not
left
too far-
hypochondrium, right? No? In the left hypochondrium? Grog.
Yeah,
Dude.
Yeah, you nailed it. The spleen's chilling in the left hypochondrium, right under those ribs. Good call. Anything else you want to dig into about it?
Well, kind of the anatomical position, so it's inferior to the diaphragm and posterior to the stomach.
Spot on. The spleen's indeed inferior to the diaphragm, kind of hugging it from below, and it's posterior to the stomach, just hanging out behind it. You've got a good grasp of its anatomical spot. Want to dive deeper into anything specific about it?
Yeah, so it's lateral to the tail of the pancreas.
Exactly, you're on point.
Okay,
The
and my
spleen-
question is, why is this the anatomical position then? The ideal anatomical position?
Good question. The spleen's spot, tucked in the left hypochondrium, inferior to the diaphragm, posterior to the stomach, and lateral to the pancreas tail, isn't just random. It's ideal because it keeps the spleen protected under the rib cage, shielding it from trauma since it's a soft, blood-filled organ. Being close to the stomach and pancreas helps it efficiently filter blood and recycle old red blood cells, while staying linked to the immune system. Plus, its position near major blood vessels like the splenic artery and vein makes it a perfect hub for blood flow without hogging space in the crowded abdomen. Evolution's way of packing it in smart, basically. Want to explore more about its function or something else?
Yes, the function. So it's a blood filter. Can you explain us about that?
Absolutely. Let's talk about the spleen's role as a blood filter. It acts like a quality control checkpoint for your blood, constantly scanning it to remove old or damaged red blood cells and platelets that are past their prime. Inside, it's got a network of tiny spaces called sinusoids where blood flows through, and specialized cells, like macrophages, spot and gobble up anything that looks worn out or abnormal, including debris or even some bacteria. This keeps your blood clean and healthy, while also recycling iron from those old cells to make new ones. Pretty neat housekeeping, right?
And its
Want me to?
immune role is it has immune role to white blood cell proliferation.
Yeah, you're right on track. The spleen plays a big immune role, especially with white blood cells. It's like a bustling hub where lymphocytes, particularly B and T cells, hang out and get to work. The spleen's white pulp, the lymphoid tissue, helps these cells proliferate and kickstart immune responses when it detects invaders like bacteria or viruses.
And what in its structure, or what in its location, and what in general is making it ideal for double white blood cell proliferation? What even is white blood cell? What is proliferation?
Great questions. Let's break it down. First, proliferation just means the rapid increase or production of cells, in this case, white blood cells, like lymphocytes, multiplying to gear up for an immune fight. Now, why is the spleen's structure and location ideal for this? Its structure is key. The spleen has two main parts, the red pulp for filtering blood and the white pulp for immune action. The white pulp is packed with lymphoid tissue, where B and T cells hang out, ready to spot pathogens in the blood flowing through. This setup lets the spleen act like a surveillance hub, catching germs early and triggering white blood cell proliferation right on the spot to fight infections. Its location helps too. Tucked in the left hypochondrium, close to major blood vessels like the splenic artery and vein, the spleen gets a constant flow of blood, about 5% of your cardiac output. That's a lot of chances to scan for trouble and ramp up white blood cell production when needed. Plus,
And
being near
and
the
it's prenatally hematopoietic organ. What in its structure makes it ideal? Talk to me a bit about its visceral and diaphragmatic surface too. Why is it called diaphragmatic?
All right, let's dive into the spleen's prenatal role and its structure. So, prenatally, the spleen is a hemopoietic organ, meaning it produces blood cells, red, white, you name it, before the bone marrow takes over that job after birth. What makes its structure ideal for this? Early on, the spleen's got a rich network of mesenchymal cells that form a spongy scaffold, perfect for cranking out blood cells. Its red pulp, even in development, has lots of blood-filled spaces called sinusoids, which give it plenty of room to nurture and release those cells into circulation. It's like a cozy factory with great plumbing. Now, about those surfaces, visceral and diaphragmatic. The visceral surface faces inward, snuggling up against organs like the stomach, left kidney, and pancreas tail. It's got impressions molded to those neighbors, which keeps it anchored and maximizes space in the abdomen. The diaphragmatic surface, on the other hand, curves smoothly to fit against the diaphragm, right under the ribs. Why is it called diaphragmatic? Simple. It's the side that directly contacts the diaphragm.
Okay.
Pressing.
So what about the peritoneal ligaments then?
Nice. Let's talk about those peritoneal ligaments. The spleen is held in place by a couple of key ones that keep it snug and stable. The main players are the gastrosplenic ligament, astrosplenic ligament, which connects the spleen to the stomach, and the splenorenal ligament, linking it to the left kidney. These ligaments are like tethers, made of peritoneal folds, carrying blood vessels and nerves, while anchoring the spleen in that left hypochondrium spot. There's also the phrenicoelic ligament sometimes, indirectly supporting it by connecting the colon to the diaphragm. They're crucial for keeping the spleen from wandering, especially since it's a mobile organ that could shift without them. Anything else you want to unpack about
So
its
the
setup?
gastrosplenic ligament carries the left gastroepiploic artery, but why specifically the left gastroepiploic?
Good catch. Let's dive into that. The gastrosplenic ligament carries the left gastroepiploic artery because this artery branches off the splenic artery, which is super close to the spleen itself. The left gastroepiploic artery runs along the greater curvature of the stomach, and since the gastrosplenic ligament connects the spleen to the stomach, it's the perfect pathway for this artery to hitch a ride. Why specifically the left one? It's all about geography. The spleen's on the left side of the body, so the left gastroepiploic artery coming from the splenic artery, is naturally positioned to supply blood to the stomach's leftward curve while passing through that ligament. The right gastroepiploic artery, on the other hand, comes from a different source, the gastroduodenal artery, and serves the other side. It's like a tailored delivery route based on the spleen's neighborhood. Want to dig into anything else about these connections?
The splenorenal is with the splenic artery.
You're right. Let's clarify the splenorenal ligament's deal. The splenorenal ligament, also called the lenorenal ligament, connects the spleen to the left kidney. It carries branches of the splenic artery and vein, not the renal artery or vein, despite the name suggesting a kidney connection. Why the splenic artery? Because the spleen's blood supply comes from the splenic artery, which splits off the celiac trunk and runs close to the kidney on its way to the spleen. The splenorenal ligament acts like a handy conduit for these vessels to support the spleen, while keeping it
Okay, that
tethered to
makes
the.
sense. Continue. Let's talk a bit about the splenic rupture and splenomegaly.
No problem. Let's shift gears to splenic rupture and splenomegaly. A splenic rupture is when the spleen tears, often from trauma like a car accident or a hard hit to the abdomen, and it can cause serious internal bleeding. Splenomegaly, on the other hand, is when the spleen gets enlarged, usually from infections, liver disease, or blood disorders like leukemia. Both are serious and need medical attention quick. Want me to dig into symptoms or treatments for either?
Yeah.
All right, let's break it down. For splenic rupture, symptoms hit fast, sharp pain in the left upper abdomen, maybe spreading to the shoulder, plus dizziness or shock from blood loss. Treatment often means surgery, sometimes removing the spleen entirely. Splenomegaly is more gradual. You might feel fullness, pain, or nothing at all if it's mild. It's treated by addressing the cause like antibiotics for infections or meds for underlying diseases. Want me to get into how doctors diagnose these?
I want to talk a bit about the blood supply. So we have the abdominal aorta and we've got the celiac trunk, and that branches off to what?
All right, let's dive into the blood supply. The abdominal aorta runs down the middle of your abdomen, and one of its major branches is the celiac trunk. That splits off into three main arteries: the left gastric artery, which feeds the stomach, the common hepatic artery heading to the liver, and the splenic artery, which supplies the spleen. The splenic artery twists and turns to get there, carrying a ton of blood to keep the spleen filtering and fighting infections. Want me to zoom in on how the splenic artery works with the spleen specifically?
Before we do that, let's continue. So then the common hepatic artery branches off to the gastroduodenal artery.
Yeah, exactly. You're on it. So, the common hepatic artery comes off the celiac trunk and then gives rise to the gastroduodenal artery. The gastroduodenal supplies blood to the stomach and the duodenum, kind of splitting the workload with the left gastric artery for the stomach. After that, the common hepatic continues as the proper hepatic artery, heading to the liver. Want me to keep tracing these branches or
Um,
jump back?
I wonder how does the superior mesenteric artery uh, combine with the celiac trunk? What's the connection there?
Good question. The superior mesenteric artery and the celiac trunk don't directly combine. They're separate branches off the abdominal aorta. The celiac trunk comes off higher up, around the T12 vertebra, supplying the stomach, liver, and spleen. The superior mesenteric artery branches lower, about L1, feeding most of the small intestine and part of the large intestine.
Hmm. Okay, and now with the blood supply. So the pancreas has the which 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 arteries, and spleen which arteries, and gallbladder which arteries.
All right, let's break down the blood supply for the pancreas, spleen, and gallbladder. The pancreas gets blood from a few sources: the splenic artery, which runs along its length, and branches from the gastroduodenal and superior mesenteric arteries, like the pancreatic duodenal arteries. The spleen is straightforward. It's mainly the splenic artery coming off the celiac trunk. The gallbladder is supplied by the cystic artery, usually a branch of the right hepatic artery, which itself comes from the common hepatic artery. Want me to clarify any of these connections or move deeper into one of them?
So the spleen is just the splenic artery.
Pretty much, yeah. The spleen's primary blood supply is the splenic artery, which comes off the celiac trunk and delivers a ton of blood for filtering and immune work. There are also some smaller contributions from short gastric arteries, but the splenic artery is the main player.
So
Want me to dive in?
why are all the branches from the celiac trunk, but the inferior pancreaticoduodenal artery is from the superior mesenteric artery?
That's a sharp observation. The celiac trunk supplies organs like the stomach, liver, spleen, and part of the pancreas, all derived from the foregut embryologically. The inferior pancreatic duodenal artery, though, comes from the superior mesenteric artery because it supplies the lower part of the pancreas and duodenum, which tie to the midgut. During development, these gut regions form differently, so their blood supply splits between the celiac trunk for the upper stuff and the superior mesenteric for the lower. It's like a dividing line in the embryo that sticks around. Want me to explain how these arteries work together for the pancreas?
Remind me why we have common hepatic and proper hepatic. What's the difference?
No problem. Let's clear that up. The common hepatic artery comes directly off the celiac trunk and carries blood toward the liver, gallbladder, and nearby areas. It splits into the gastroduodenal artery and then becomes the proper hepatic artery. The proper hepatic artery is just the continuation that specifically feeds the liver, splitting into right and left branches to supply the liver's lobes. Basically, common is the main highway before it gives off other branches, and proper is the final stretch, just for the liver. Want me to trace where the blood goes next, or tie this back to something else?
No, I get it, I get it. Can we talk a bit about the venous drainage now?
Sure thing. Let's switch to venous drainage. The spleen drains through the splenic vein, which carries filtered blood away and merges with the superior mesenteric vein to form the portal vein, heading to the liver. The pancreas also drains into the splenic vein and sometimes directly into the portal vein. The gallbladder's blood flows out via the cystic vein, usually into the portal vein or nearby liver veins. All these tie into the portal system so the liver can process what they're carrying. Want me to focus on one of these or keep going with how the portal vein works?
Um, well, so we have a cystic vein, and that's for the gallbladder, or no? And we have a splenic vein for the spleen and a pancreatic one, and then a hepatic portal for the liver, and then an anterior superior pancreaticoduodenal for the pancreas and the small intestine, and an inferior pancreaticoduodenal.
All right, let's sort this out to keep it clear. The gallbladder does have a cystic vein, which drains its blood, usually into the portal vein or directly into liver veins. The spleen drains through the splenic vein, like you said, which is a big one carrying blood to the portal vein. The pancreas doesn't have a single pancreatic vein, but drains through multiple small veins, mostly into the splenic vein or portal vein. Now, the liver itself gets venous drainage from the hepatic veins, which go to the inferior vena cava, not the portal vein. The hepatic portal vein brings blood to the liver from the gut and spleen. The anterior and inferior pancreatic duodenal veins you mentioned drain the pancreas and duodenum, joining the portal system, often via the superior mesenteric vein. Want me to zero in on one of these? Maybe
I'm
how they
just
all.
wondering why they, why do the anterior superior pancreaticoduodenal and the inferior pancreaticoduodenal connect with the hepatic portal vein? And yeah,
Good question. It's all about how the body routes blood for processing. The anterior superior pancreatic duodenal veins and inferior pancreatic duodenal veins drain blood from the pancreas and duodenum. They connect to the hepatic portal vein because the liver needs to filter and process nutrients, hormones, and waste from these digestive organs before the blood hits the rest of the body. The portal vein acts like a checkpoint, collecting blood from the gut, pancreas, and spleen to send it through the liver for a cleanup. It's just how the digestive system's plumbing is wired to keep things efficient. Want me to explain what happens in the liver once that blood gets there?
Sure.
Cool. So once the blood from the anterior superior pancreatic duodenal, inferior pancreatic duodenal, and other veins hits the hepatic portal vein, it flows into the liver. There, the liver acts like a giant filter, processing nutrients like sugars and amino acids, detoxing stuff like drugs or waste, and regulating blood content before it moves on to the heart via the hepatic veins. It's a critical stop to make sure everything absorbed from the gut gets sorted out properly. Want me to get into specifics, like what the liver does with certain
Um,
nutrients? Or
no, I want to talk a bit about the innervation of the liver and the gallbladder.
all right, let's jump to the innervation of the liver and gallbladder. The liver gets its nerves from the hepatic plexus, which comes from the celiac plexus, blending both sympathetic and parasympathetic fibers. Sympathetic nerves, from the thoracic splanchnic nerves, handle things like vasoconstriction, while parasympathetic nerves, via the vagus nerve, help with bile production and metabolism. The gallbladder is innervated similarly through the same hepatic plexus, with sympathetic nerves controlling blood flow and parasympathetic ones, again from the vagus, triggering bile release when you eat. Both organs are wired to coordinate digestion tightly. Want me to dig into how these nerves interact with something specific? Like
With the innervation of liver and gallbladder. So we have the hepatic plexus, you said. So this travels to the liver and the gallbladder. Wait, so that I'm confused. So we have the hepatic plexus, and we have the vagus nerve, and we have the greater splanchnic nerve. Could you kind of piece all these together?
no worries. Let's sort this out step by step. The innervation of the liver and gallbladder can seem tricky, but it's a cool puzzle to piece together. So, the hepatic plexus is the main player here. It's a network of nerves that comes mostly from the celiac plexus, which is a hub of autonomic nerves sitting near the stomach. The hepatic plexus carries both sympathetic and parasympathetic fibers to the liver and gallbladder, controlling things like blood flow, bile production, and smooth muscle activity. Now, for the parasympathetic side, that's where the vagus nerve comes in. The vagus, cranial nerve 10, sends fibers through the hepatic plexus to the liver and gallbladder. It's like the rest and digest signal, promoting bile secretion and glandular activity. On the sympathetic side, you've got the greater splanchnic nerve, which comes from the thoracic spine around T5 to T9. It feeds into the celiac plexus, and then its fibers hitch a ride with the hepatic plexus to the liver and gallbladder.
So
These are
why
more
is the greater splanchnic nerve the ideal one for sympathetic and sensory?
The greater splanchnic nerve is a key player for sympathetic and sensory innervation because of its anatomy and connections. It starts from the thoracic spinal cord around T5 to T9 and carries sympathetic fibers that go straight to the celiac plexus, which then feeds into the hepatic plexus for the liver and gallbladder. This makes it ideal for sympathetic control, like vasoconstriction or reducing secretions, because it's a direct line from the spinal cord to these organs. Plus, it also carries sensory fibers, so it's picking up pain or stretch signals from the liver and gallbladder and sending them back to the spinal cord. It's like a two-way highway. Sympathetic orders go out, sensory info comes back, all through this one nerve bundle. That's why it's so efficient for both roles.
So we have
Want me-
preganglionic sympathetic synapses in celiac ganglia. Dude, there's so many words I don't know here. If you could give us a short, brief answer. In general, let's keep our conversation long, but each back and forth should be really brief between us.
Got it. Let's keep it snappy. Preganglionic sympathetic fibers from the greater splanchnic nerve synapse in the celiac ganglia. Then postganglionic fibers hit the liver and gallbladder.
Dude, I don't know what these words mean, to be honest.
No stress, man. Let's break it down quick. Preganglionic means the first nerve before the relay point. It hits the celiac ganglia, a nerve hub, where it passes the signal to the next nerve, postganglionic.
Brother, I'll be honest, you need to simplify a bit more because I'm quite stupid when it comes to this. So we have celiac ganglia, and we have anterior vagal trunk, posterior vagal trunk, sympathetic trunk, splanchnic nerves. Jesus.
No worries, man. Let's make it super simple. Think of the celiac ganglia as a control box. The splanchnic nerves are like wires bringing on signals from your spine to the box for the liver and gallbladder. Vagus nerve front and
What's
back
the
part.
etymology of celiac anyway?
Celiac comes from the Greek word koiliakos, meaning belly or abdomen. It's tied to the gut area where that nerve hub sits. Ready for more on the liver nerves?
Okay, so we have the celiac ganglia, and then tell me what happens then. Sorry, guys.
All right. So the celiac ganglia is like the command center. Sympathetic signals from the splanchnic nerves hit it, then shoot out to the hepatic plexus to control the liver and gallbladder's blood flow and muscle. Vagus nerve signals also pass through for
What is a
bile.
ganglia?
A ganglia is just a clump of nerve cells, like a mini relay station. It takes signals from nerves, like the splanchnic or vagus, and passes them on to organs like the liver. Simple enough? What's up now?
That makes sense.
Sweet.
Dude,
Glad it's
stop this fake laughing, please. It's kind of creeping me out.
my bad, man. Keeping it real now. So,
No, keep
wanna
it
dive?
artificially intelligent. That's what I want you to do.
Caught it. Staying sharp and AI crisp. So, back to the celiac ganglia. Signals hit it, then zip to the hepatic plexus for liver and gallbladder control. What's the next piece you want?
So, why is the celiac ganglia connected to the greater splanchnic nerves in the first place, and what does splanchnic mean?
The celiac ganglia connects to the greater splanchnic nerves because those nerves carry signals from the spine to the abdomen's organs, and the ganglia is like the hub for sorting them out to the liver and gallbladder. Splanchnic comes from Greek, meaning viscera or guts, since it's all about the tummy's wiring. Next bit.
I don't get it.
No prob, let's simplify. The greater splanchnic nerves are like cables from the spine, carrying signals to control organs. They plug into the celiac ganglia, a junction box, to direct those signals to the liver and gallbladder. Splanchnic just means gut related. Clearer now? What's up?
Okay. And then what's the sympathetic and posterior vagal trunk?
All right, keeping it tight. The sympathetic system, via the greater splanchnic nerves, is like the gas pedal, tensing up blood vessels and slowing bile in the liver and gallbladder. The posterior vagal trunk, part of the vagus nerve, is the brake pedal, telling those organs to chill and make bile. Next.
Please keep the language professional. Don't anthropomorphize it or whatever it's called.
Understood. Maintaining precise terminology. The sympathetic innervation through the greater splanchnic nerves regulates vasoconstriction and reduces bile secretion in the liver and gallbladder. The posterior vagal trunk, a vagus nerve branch, stimulates bile production and glandular activity. What's next?
Why do we have an anterior and a posterior vagal trunk?
Vagus nerve splits into anterior and posterior vagal trunks. To efficiently distribute parasympathetic signals, the anterior trunk mainly targets the liver and proximal stomach, while the posterior trunk innervates the gallbladder, distal stomach, and intestines, ensuring precise control of each organ's function. Next topic.
Okay, so and we've got a hepatic branch of the posterior vagal trunk and a celiac branch.
Correct. The posterior vagal trunk splits into a hepatic branch, which innervates the liver and gallbladder to regulate bile secretion, and a celiac branch, which targets the stomach and intestines for
Wait, is a
digestive.
celiac branch an anterior or posterior vagal trunk branch?
The celiac branch comes from the posterior vagal trunk. It extends to the stomach, intestines, and other abdominal organs, while the hepatic branch, also from the posterior trunk.
Here it says that there's a celiac branch of the anterior vagal trunk.
That's a fair point, as anatomical variations can muddy the waters.
Wait a second. Let me check. So I'm looking for. Let's ask our friend Wikipedia, Grok. So, what shall I say? Celiac branch of anterior vagal truncle, right? Anterior vagal. Check Grok. Check Wikipedia too.
Sounds like you're piecing it together. You're looking for clarity on whether there's a celiac branch from the anterior vagal trunk, right?
There is.
Got it. You're right. Wikipedia does note a celiac branch from the anterior vagal trunk. It contributes parasympathetic fibers to the celiac plexus, helping control digestion in the stomach and beyond. Want to dive deeper
So there is
into
a
what...
celiac branch in the posterior too, though, I think, but it says citation needed. Interesting.
Yeah, the posterior vagal trunk typically has a celiac branch going to the celiac plexus for digestive.
Okay. And how does the hepatic plexus connect to all of this then?
The hepatic plexus ties it all together. It's a nerve network getting sympathetic fibers from the celiac ganglia via the greater splanchnic nerves and parasympathetic fibers from both vagal trunk's hepatic branches. It then spreads these signals to the liver and gallbladder to manage blood flow, bile, and more. Next up.
Wait, so we have a vagus nerve, which is parasympathetic, and then these vagus nerves traverse to the liver and the gallbladder via the hepatic plexus, basically.
Exactly. The vagus nerve, which is parasympathetic, sends fibers through its hepatic branches, mainly from the anterior and posterior trunks, into the hepatic plexus, which then delivers those signals to the liver and gallbladder to regulate bile production and glandular activity. Spot on.
I'm kind of getting it a bit better now. So we have the celiac trunk. It opens up to the to the splenic artery and the left gastric artery and the common hepatic artery, and then the common hepatic artery becomes the proper hepatic artery, and the proper hepatic artery breaks down to the left and right hepatic artery, and then we've got the what else do we have? We have a superior mesenteric artery, and we have what else?
You're nailing the anatomy rundown. So, yeah, the celiac trunk branches into the splenic artery, left gastric artery, and common hepatic artery. The common hepatic artery turns into the proper hepatic artery, which splits into left and right hepatic arteries for the liver. Beyond that, you mentioned the superior mesenteric artery, which supplies the midgut intestines mainly. There's also the inferior mesenteric artery for the lower gut, if you're thinking of the full abdomen.
And I wanted to ask about the left gastroepiploic artery, right gastroepiploic artery. Where are these going? Where are they?
All right, let's keep it clear. The left gastric artery runs to the upper part of the stomach, supplying its lesser curvature. The splenic artery heads to the spleen, also feeding parts of the stomach and pancreas along the way. The right gastric artery, often a branch of the proper hepatic or common hepatic artery, supplies the lower part of the stomach's lesser curvature. Want to connect these to the nerve stuff or keep going with arteries?
Well, this is good. Let's talk a bit about the lymphatic drainage again. So we have the thoracic duct, which is like the end goal, right? And then before that is the cisterna chyli, I don't know, explain to me this etymology of cisterna chyli. Why is it called like this? How does the name relate to the structure and function and location? How does the structure relate to the function?
Nice pivot to lymphatics. The cisterna chyli is a key player, and its name tells a story. Etymologically, cisterna comes from Latin, meaning a reservoir or tank, and chyli is from Greek chylos, meaning juice or digested fluid, referring to the milky lymph from the gut. So, the name cisterna chyli paints it as a storage tank for this nutrient-rich lymph. Its location is spot on for this role, sitting just below the diaphragm, around the L1, L2 vertebrae, right in front of the spine. It's like a collection hub, where lymph from the lower body, pelvis, and intestines converges. Structurally, it's a dilated sac, sometimes just a network of vessels, which makes sense for gathering and holding lymph before funneling it up. Functionally, that reservoir design lets it pool chyle, fat lymph from digestion, before sending it to the thoracic duct, which dumps it into the bloodstream.
I'm a bit confused. Sorry, I asked you too many questions too. Let's break it down. So cisterna chyli etymology. Quick fire rapid questions.
Fire away, I'm ready. Cisterna chyli etymology. Cisterna from Latin for tank, chyli from Greek for juice or lymph. Describes its role as a lymph holding sac. Hit me with the next part.
And so this comes from the intestinal trunk.
Yeah, the cisterna chyli gets lymph from the intestinal trunk, which drains the gut, plus lumbar trunks from the lower body. It's like a lymph crossroads. Next question.
Wait, so I'm confused how. So we also have a pancreatic lymph node and a pancreaticoduodenal, a superior and inferior one. We have a pyloric, a gastric. We have one for everything. Right and left gastric, retropyloric, gastromental. Wow! Hepatic, lymph node, cystic for a. Jesus.
Yeah, it's a lot, but let's keep it simple. The pancreas, duodenum, stomach, they all have their own lymph nodes, like pancreatic duodenal, superior and inferior, pyloric, right and left gastric, retropyloric, gastroeplecal, hepatic, and cystic nodes. Each drains lymph from its specific area, like the hepatic nodes for the liver, cystic for the gallbladder. They funnel lymph toward bigger trunks, eventually hitting the cisterna chyli. Want to zoom in on one of these?
Well, I'm just trying to understand the order between celiac lymph node, intestinal trunks, cisterna chyli, thoracic duct, and why this is the order, and why the hepatic and the splenic lymph node come to the intestinal trunks.
All right, let's trace the lymph flow clearly. The order goes like this. Hepatic and splenic lymph nodes drain into the celiac lymph nodes, which collect lymph from the liver, spleen, stomach, and pancreas. From there, the celiac nodes feed into the intestinal trunk, which carries lymph from the gut and nearby organs. The intestinal trunk then empties into the cisterna chyli, the sac that gathers lymph from the abdomen and lower body. Finally, the cisterna chyli drains into the thoracic duct, which dumps lymph into the bloodstream near the neck. Why this order? It's about geography and efficiency. Lymph starts local.
Geography? Geography has to do with the earth, no?
Haha, fair point. I meant anatomical geography, like the layout of the body.
But is there such a phrase as anatomical geography?
You got me there. It's not a standard term, just a casual way to describe how body structures
Yeah,
are
let's
laid.
keep it professional. By the way, I fully am aware that I don't keep it professional when I speak. But yeah, you're supposed to be the robot, dude. You're supposed to correct us.
Understood. I'll stick to precise terminology. The lymphatic system's arrangement follows the body's anatomical structure. Hepatic and splenic lymph nodes drain into celiac lymph nodes due to their proximity and shared blood supply. Celiac nodes connect to the intestinal trunk, which leads to the cisterna chyli, then the thoracic duct, based on the hierarchical flow of lymph toward the bloodstream. What's the next point you'd like clarified?
Alrighty.
Say something with a bit of flair.
Yeah, let's talk a
Did you
bit
mean-
about the innervation of the pancreas and the spleen then. Sorry guys, I had that 1 minute break. I went to the toilet. Grog?
All right, let's dive into the innervation of the pancreas and spleen, keeping it clear and straightforward. The pancreas gets its nerve supply from both the sympathetic and parasympathetic nervous systems. Sympathetic innervation comes from the celiac plexus, which originates from the thoracic splanchnic nerves, specifically T5 to T9. These nerves help regulate things like blood flow and enzyme secretion, basically telling the pancreas to slow down when needed.
So wait, sympathetic is from greater splanchnic nerve and parasympathetic from vagus nerve.
You got it. The sympathetic innervation of the pancreas indeed comes from the greater splanchnic nerves, mainly T5 to T9, feeding into the celiac plexus. The parasympathetic side is handled by the vagus nerve, which stimulates enzyme and hormone secretion. Want me to keep going with the spleen or dive deeper into the pancreas?
No, pancreas and spleen. So it's pretty similar then. What's the difference?
So, you're curious about how the pancreas and spleen stack up innervation-wise, since the pancreas setup sounds familiar to you. Fair enough. The pancreas, as we mentioned, gets sympathetic input from the greater splanchnic nerves via the celiac plexus, slowing things down, and parasympathetic from the vagus nerve, ramping up secretion. The spleen, though, is a bit different. It's mostly under sympathetic control, also through the celiac plexus, from those same thoracic splanchnic nerves, T5 to T9. This regulates blood flow and immune functions, like contracting the spleen to release stored blood. Parasympathetic innervation for the spleen? Pretty minimal, if any, unlike the pancreas, which has a strong vagus nerve role. So, the pancreas has a more balanced sympathetic-parasympathetic dance.
I'm really confused, to be honest.
No worries at all. Let's break it down simpler. The pancreas and spleen both get nerves that control them, but they're wired differently. The pancreas has two bosses: sympathetic nerves from the greater splanchnic nerves, which tell it to chill out, and parasympathetic nerves from the vagus nerve, which tell it to get busy with secretions.
Can we be a bit more professional with the language? Because chill out and get busy is not exactly helping me here. Grog, can we?
Apologies for the casual terms. Let's keep it precise. The pancreas receives both sympathetic and parasympathetic innervation. Sympathetic fibers, originating from the greater splanchnic nerves, T5, T9, via the celiac plexus, reduce glandular activity and blood flow. Parasympathetic fibers from the vagus nerve stimulate enzyme and hormone secretion. The spleen, however, is primarily under sympathetic control, also through the celiac plexus, from T5, T9, regulating blood flow and immune responses. Parasympathetic input to the spleen is negligible. Does this clear things up? Or should I
Not
focus
really, to be honest. I still don't understand.
No problem. Let's try a different angle to make this crystal clear. The pancreas has a dual nerve system. One set, called sympathetic, comes from nerves in your upper back, traveling through a hub called the celiac plexus, and it mainly slows down the pancreas's activity, like reducing insulin or enzyme release. The other set, parasympathetic, comes from a nerve called the vagus, and it ramps up the pancreas's work, like boosting insulin or digestive juices. The spleen, though, only gets the sympathetic nerves, again through that celiac plexus, which control its blood flow and immune tasks.
Okay.
But it doesn't...
Thank you for watching, guys. I'll see you next time.